periprosthetic fractures are not uncommon around the knee. And of the all predisposing factors, osteoporosis tops the list as one of the major predisposing factor. Now, whenever you're planning for treatment of any periprosthetic fracture around the knee, it is of paramount importance to reasonably rule out loosening of the implant by history, by serial films if available, blood work, and it's mandatory to get a CT scan done to look for any loosening if you can see, or to have the morphology of the fracture. Various classifications are available, but the practical classification, Arora is quite commonly used, but I find this classification, classification, very practical. It has three categories. Type 1, fracture proximal to the femoral component. Type 2, when the fracture originates at the proximal end of the femoral component and goes proximally. And type 3, in where the fracture originates distal to the top end of the flange of the femoral component and goes distally. And in all these three categories, it is must to see is prosthesis loose. What are the treatment options? Non-operative management has limited indications. Do we have presenter view on this? Is a presenter view high? So non-operative management has very limited indications in these cases, because in 15 to 30% of cases, you require re-surgery if you treat them conservatively. Thank you, I've done it. Now, what are decision-making factors for when you decide for a surgical treatment? It is on location of fracture, comminution, bone quality, what is available bone stock in the fracture fragment, and most important, is the prosthesis loose or stable? And do take into account age and comorbidities, how far can you go in surgery. Treatment options, non-operatively, very less number of cases. Operative, you need to see is the prosthesis stable, plus is there sufficient quality of bone in the distal fragment to fix. If so, reduce and fix either by an intermediate nail or a plate. But if prosthesis is loose, or the fracture pattern is such that you can't get a fragment to hold, or this poor bone stock, think of revision and you can use a hinge or a mega prosthesis. But in all these situations, keep in mind general condition and comorbidities, how far can we go in big surgery. Non-stable prosthesis, one can use a locking plate, single locking plate or double locking plate, or an intramedullary nail if there is a box, or a locking plate plus intramedullary nail. Dual plating is highly advisable if there is comminution or poor bone quality, unstable fracture pattern, or the main fragment is lying medially. When you are fixing, if you are not sure, once you have done a fixation on the lateral side, do a varus valgus stress under image, and if the fracture is unstable, add one more plate. Sharing few examples with you. 69-year-old female, Balter TKR done March 19. 3.5 years later, she reported to us with a periprosthetic fracture in the femur. CT scan shows available bone stock in the fragment. This is sagittal cut and there's a coronal cut. Adequate bone available. Dual plate fixation was done. Stable assembly found on table. And this is 6 weeks follow-up. Some bone formation on the posterior side. 4 months follow-up. Better situation, fracture is uniting, and these are two comparative X-rays, the bone formation progressing on the posterior side, and it was not opened much. At 1.5 year follow-up, it was rock solid. Another patient, 59-year-old female, had earlier an intertrochanteric fracture with PFN in situ, underwent Balter TKR. This is 6 weeks follow-up. The bone is osteoporotic. We had used primary stem in this case. And 4 months later, she reported with periprosthetic fracture because physiotherapists were teaching her how to walk backwards. And this is 4 month post TKR. SU type 2, poor quality bone. The component was stable. The bone is eggshell and there is massive comminution. I'll show some CT films. But there's still some bone available in the distal fragment for fixation. This sagittal view, and in coronal view, there are undisplaced fracture going down. In this case, we are able to fix the fragment with dual plating. we should have gone higher up to prevent interprosthetic fracture. We should have put a bigger plate on the medial side. And this is 4 months follow-up, started uniting, and at 1 year follow-up, but it was solidly united. So these fractures do take time to unite. The bone quality is poor. Now, if there is inadequate bone stock in the distal fragment, I'll show one example. 76-year-old male, SU type 3, comminuted fracture, and poor quality bone combination on the medial side. CT scan shows less bone available in the distal fragment. Patient already had a severe patella baja. This is at the time of fracture. And we ended up doing a distal femoral replacement in this case to mobilize the patient early. This is 3 months follow-up, and patient was doing well. This is 4 years follow-up. Now, what do we do if the prosthesis is loose? If the prosthesis is loose, then you have to plan for revision surgery, and depending upon amount the bone available in the metaphysis, plan for a hinge or a megaprosthesis. Tibial periprosthetic fractures, less commoner than femoral periprosthetic fractures. The most commonly followed classifications are of Felix. 4 types: type 1 near base plate, type 2 near the stem, around the stem, type 3 distal to stem. In fact, this is just a classification. Majority of fractures, they fit into either 1 and 2, 2 or 3, because they are not just around in one area. Type 4, fracture of tibial tubercle, and subclassification ABC into A, stable implant, B, loose implant, and C, intraoperative fracture. Now, these periprosthetic tibial fractures, it all depends. If prosthesis is stable, Felix type A, undisplaced, one can think of conservative, but better to fix them. If it is displaced, use plate for fixation. Prosthesis is loose, you need revision, either by using a cone or sleeve or some other gadgetry or a megaprosthesis. Another one example of fixation of tibial periprosthetic fracture by dual plating, which united well. This is from literature. Another patient, 74-year-old female, implant was suspected to be loose. There was comminution. We went ahead with both the plannings of fixation as well as replacement, and it was comminuted intraoperatively. We landed up putting a hinge in this case, and the patient did well. This is 2 years follow-up. Later on, patient did again had a fall and had a patellar fracture. Now, how about periprosthetic fracture of patella? Quite rare, and they have been classified into 3 categories. Number 1, well-fixed component, intact extensor mechanism, one can treat conservatively. Type 2, stable component, but extensor mechanism disrupted. And type 3, when the component is loose. Now, for periprosthetic patellar fracture, if it is stable implant, undisplaced, one can think of treating conservatively, but if it is displaced, you need to fix it, either by you do a ORIF, or if the fragment is small, one can think of partial patelectomy. But if the implant is loose, there are various options. You can do revision or patelloplasty or excision arthroplasty or total patelectomy. Sharing with you a few examples. This was undisplaced, treated conservatively, did well. Another patient who had unresurfaced patella, tension band boring was done, ultimately did well. And last example, where the distal fragment is very small, we use an anchor suture to suture the ligamentum patellae with it, and it did well at the end. This is the last slide, I think. And she did well.